Hi, everyone, and welcome back to ISPEC Talks, where we explore the intersection of research, policy, and implementation with leading experts from around the world. Today, I'm beyond thrilled to be speaking with close friend and colleague, Dr. Adam Rose, a physician, implementation scientist, and associate professor at the Hebrew University Hadassah School of Public Health. Adam brings a rare combination of clinical experience, health policy expertise, and a deep understanding of implementation science. Before moving to Israel, Adam worked for many years in the VA, the Veterans Health Administration, and then at the RAND Corporation, and led national initiatives in the US, focusing on improving quality and safety in primary care. His research has consistently pushed for practical, scalable solutions to real-world health system challenges. Adam, we are so excited to have you, and thank you for joining us.
Thank you for having me.
Let's begin with your journey. You've worked in both the US and Israel health systems. How did your path take you from clinical care to implementation science and policy work?
Okay, so I'm going to start when I was a resident in internal medicine. So the year was 2001, and I was just several months into my internship in internal medicine, and I was responsible for a whole bunch of stuff. And I used to wake up at night wondering if I had remembered to give people their DVT prophylaxis, or remembered to, or had I forgotten to address that low potassium. I used to literally sit up in bed.
Stress.
Yeah, I know, and because there were no systems to help me remember, and so it was all on me. And then this article came out by Elizabeth McGlynn and others in the New England Journal of Medicine, and the bottom line was that 55% of recommended care is delivered to adults in the United States. So this was a very ambitious paper. It's been cited a whole bunch of times since then, obviously. But I looked at this and I'm like, yeah, this is the problem. And I'm like, and these people, are doing something about it. Like, they're doing a certain kind of research that's, documenting what's going on in health systems, improving what's going on in health systems. So to give you an idea of how long ago this was, I sliced it out of the magazine with a razor blade and I pinned it on my corkboard. And I said, I'm going to do something about this someday. So not everybody gets to do like a holistic study of all quality of care delivered to several thousand adults. That was supported by a huge grant. And also, we don't need to over and over do this omnibus study of how are we doing, although another one at this point would be good. But my approach is more to get into each of the things that they found was wrong, right? They had about 500-600 measures that they said on average were being done 55% of the time. So I've helped address a few of them. And I've also gotten into a few that they didn't have in their study because they hadn't gotten up to that yet, or that was not included in their conception of quality that could be measured. So kind of skipping, after residency, I was looking for what to do. I landed on a general internal medicine fellowship at Boston University and the VA. And there I got a master's in health services research, an MSc in health services research, which gives you a very different sort of direction than just studying epidemiology. You get into sort of messy clinical data sets and clever ways to solve data problems. And it's a very different orientation than epidemiology, where you're all just constantly pursuing kind of perfect data, perfect internal validity, and methodological rigor, and semantic ways to point out that other people have called the study design something slightly wrong compared to what you would call it. And then, I entered that fellowship kind of up in the air about whether I wanted to be a clinical educator or a clinician researcher. And just a few weeks into that, I was like, I'm definitely going to be a researcher. This is so much fun, even though I hadn't produced anything yet and was still just doing literature searches. But I was like, this is amazing. It's, because there's a whole part of your brain that you just don't get to use when you're in medical school and when you're a resident. And then sort of how did I get launched into my career? I mean, you can call me several things, but probably the thing that I most comfortably call myself is a quality of care researcher, which naturally leads to measuring and also then improving quality of care. So how did I get into that? Well, I had two mentors on my early research papers. One is an expert in risk adjustment and quality of care, and one is an expert on anticoagulation. And I looked at this and I thought about this, when I was out for a run or whatever. And I said, nobody's ever put these together. All the people who study anticoagulation are like epi heads who do clinical trials and are not doing health systems research. And people doing health systems research have not really turned their attention to this area. And it was interesting because it was mostly managed by pharmacists and not by doctors, which is a kind of interesting variation because everyone's always measuring what doctors do. And I had this line that I used to say when I went around doing my stump speech that if warfarin, which is the anticoagulant that they had back then, now there are others, if warfarin were a surgical procedure, it would be the most morbid, highest cause of death surgical procedure that we do, or one of them. And we would have a whole program dedicated to studying how well it's done, improving it, comparing how different people do it. But we just think of warfarin as like this thing. You either get it or you don't. But it actually has to be managed very skillfully. And so I will say that over the next almost 10 years, the pharmacists who manage warfarin for at least part of the time came to appreciate what I was doing because I basically systematically answered most of the questions that they had about how best to manage warfarin. Not from the standpoint of an epidemiologist, or really how to manage a warfarin clinic, a clinic that's dedicated to kind of handling people's ongoing warfarin therapy. And I made a lot of friends in that world. Eventually, my thoughts were kind of bigger than that. I got into like suboptimal prescribing in general at the Rand Corporation. I got into much broader things and sort of the world of big program evaluations. And when I came to Israel, I did activate my medical license, although I'm not really using it except to prescribe creams for my kids sometimes. But what I discovered is that I also like to teach. I had given 1-hour lectures, of course, but I'd never taught a whole course. So now I'm doing the research part here in Israel, for better and for worse, and we can talk about that. And I'm teaching, which I really like. So that's kind of a little bit of like how I got here.
All right. You said two things I take away from this. You sound like a young Doogie Howser. Of course, I'm dating myself because
I wasn't that young.
No, but you were, meaning already in 2001, you said you were already thinking these bigger questions when it was still very new, and I think you were young in 2001. I didn't know you then, but
I
what
was
I also
27.
loved
I was 27, but no, I was
that's pretty young.
frustrated. I was frustrated because I didn't think it had to be this way. Like when I was seeing people in the clinic, like there was this paper checklist, the first thing in the chart, right? First of all, there's this chart. You don't always get the chart, right? So paper chart, paper orders, no clinician, physician order entry thing yet on the computer, right? The computer was like, started to happen like at the end of my first year of internship. So but we didn't really start using it until my third year. And, there was this paper flow thing stapled into the chart at the beginning. And it had like a row for colonoscopies and a row for mammographies and a row for pap smears. And I was like, why are we using 15-year-old computers? And my brother was working in the world of finance. And the technology that he was using had been around for 20 years and could have done why is healthcare so far behind? And why is this not easier? And why do I have to be Superman just to remember to get my patient a colonoscopy? Right. So anyway, it's, yeah.
And there was the tech. I mean, we're not going to go down this road, but that tech did exist in Israel at that point, I think.
That tech
I
has
could be wrong,
existed
but
for
I
a
think
long time. The question is not, does the tech exist? It's actually funny, people who are say they're into digital medicine, they're, I remember there was this guy who's a great researcher who worked with me at the VA, and his office was across the hall from me, and he was like very earnest and very well trained, and he was a really good writer. And I actually used to ask him to read all my stuff because he was so good. But he was like doing this thing about like, could veterans learn to use the internet? And this was like, between 2005 and 2010. It's not exactly, and then like people eventually get into like M health and like, can people use smartphone apps? But it takes so long to do a research project. That's the other thing. I mean, you're an implementation scientist, but like, it takes the idea percolates in your head for a year, and then you like submit a grant, right? Or if there's a preliminary stage of the grant, by a year you've submitted the grant, and then it's like getting reviewed for a year. And if you have to resubmit it, that's another year. And then you do the work for 3 years plus a year of like, let's say, no cost extension. And then, if you're not one of these people that writes papers while the grant is still ongoing, which I actually do most of the time, but many people don't, then like you start the process of writing and publishing your papers. By the time you publish the paper, it's 8 years after you first germinated this idea. And that's not even included in the 17 years everyone likes to quote about how long it takes for change to happen, right? That 8 years is a whole other thing before the 17 years. So it's really 25 years. And so this is why people who study like digital health are like studying stuff that was like, a big deal 5 years ago because of that timeline, right?
Right.
So
Right.
anyway.
But something else that I love that you had said at the beginning when you described your first study was you worked with the pharmacists, which, so often when you're talking about prescribing or, okay, you go straight to the doctors, but there's so many allied health professionals that have such a strong role. And I love that already at the beginning of your journey, you were considering the other professionals, not just physicians.
So there's been a whole movement to make quality measurement more meaningful. And there are different kind of strands of that. One is to focus on what patients find important, which is important, right? I'm not denigrating any of these things. And one is to make the measures more intelligent, to measure more of what matters and less of what doesn't. One is to avoid unintended consequences of measurement that's clumsily applied and gets people to do stuff that is not, is counterproductive. The aspect of improving quality measurement that I find most compelling, even though you don't hear about it nearly as much, I'm like maybe the sole voice promoting it, is that there's just a lot of stuff we're not measuring. Like if you look at, that old saw that like when you take, hallucinogenic mushrooms, which I've certainly never done, that there's like the other 90% of your brain gets used. The 90% that you
Really?
don't use. Yeah, there's a lot of tissue in your brain that like is
No,
mostly
that
not
I
doing.
know, but I didn't know that when you take the mushrooms, that other 90% is
Well, I
activated.
don't know if you use all of it, but you're using some of the 90% that you're not always using, right?
Right.
And there's a lot of like consciousness in our, like our minds can do a lot of things that we just don't take it there. Even our bodies can do a lot of things that we don't take them there. Like really good workouts gets you to use muscles that you don't usually use. Like, walking for exercise, for example, is great for you, but there's a lot of muscles that don't get involved. So I think that quality of care, if you were to think about like what matters in quality of care, there's so much that we don't measure. Like getting people a hemoglobin A1C and controlling their blood pressure is super important. I'm into it. And like it's easy, not easy, it's relatively easy to get research funded on those things. So people study it, it's great. But like there's more than that. There's like end of care life decisions and pharmacist care and, applying sort of best practices to prevent pressure ulcers. There's so many things, and not all of them are done by doctors. And also, not all of the stuff that's done by doctors are done by primary care doctors. There's a terrible imbalance that primary care doctors just get measured to death, and other doctors hardly ever at all. And I used to argue to the pharmacists that the fact we wanted to measure their activities was a mark of esteem. That what we think, that we think that what they're doing is serious enough and important enough to warrant being measured. Some of them accepted that more easily than others.
Um, okay, so you often speak about making research actionable. So what do you think researchers still get wrong about that process? Meaning,
I can't say I've solved it, but I didn't know. So I I personally do research that's kind of somewhere at the boundary of like clinical medicine and health services research, just because, that's just like my comparative advantage is that I understand clinical medicine, even if I'm a little rusty and I may not know the names
That's
of
a
the
huge,
drugs.
huge, trust me, as someone that doesn't, it's huge.
Right. And so, what you have is like maybe more strength in things like conceptual models. And oh, even though I like stuff like that, but like, you have a PhD, there's a certain erudition associated with that. But you're right. I have like kind of an intuitive understanding of what goes on in clinical settings. And that's kind of my conceptual model, always, or one of my biggest ones. But wait, I'm sorry. What was the question?
It's how do you make the research itself actionable?
Yeah. So, look, I mean, I think I naturally try to pick things that are clinically actionable or policy actionable. Certainly my warfarin work, as I said, like the pharmacists who are managing warfarin, they got it. They got it completely. Like, well, okay. Some of them like had, were not didn't really believe in research and didn't really believe that experts could tell them anything and whatever, and like I'm not talking about those, but everyone who was like open-minded, anyone from like somebody who's a research head to somebody who was kind of neutral and just kind of saw what I was doing, they all got why it was good that somebody was doing like an actual empirical study of whether patients who are in range should be followed in 4 weeks, 6 weeks, or 8 weeks, like, or things like that, not things that nobody had ever answered. Now I did it with observational data, which led some people to, dismiss it, but I'm like, nobody's going to randomize this. So this is the best you're going to get. Either there was nothing and now I gave you something, either use it or don't, but this is what I, found.
This is the best that's coming your way.
Yeah. I mean, look, the other thing is I know that your podcast and your whole enterprise is about implementation science. And I didn't mention implementation science. The thing is that in the VA, you had to do implementation science. Like basically when I kind of talked about how I got involved in medicine kind of right at the transition point from paper records to computer records. Like at the beginning of my internship, we were using only paper records. By the end of my residency, we were basically using only computers. In the VA, when I started, it was still the tail end of health services research's golden period in the VA. And the newest thing is that you had to be able to do mixed methods, that you had to be able to use like numerical data and also qualitative. So I definitely got into that. And my career development award that supported the first 5 years of my career in the VA was a classic mixed methods, using a big database and talking to people, and doing qualitative research. Over the sort of latter 5 years I was in the VA, because I was there for like 11 years, that's when they basically made everyone get into implementation science. They started the query program. There was a lot of money available for people who were willing to do implementation programs. And I think I kind of looked ahead to this even when I was submitting my Career Development Award grant in 2008. Because I said that immediately following the three aims of my 5-year career development grant that I would submit an implementation project to implement everything we did with warfarin. And that was like my first big implementation project. So I was already looking ahead to that. I think my advisor kind of could read the tea leaves of where things were going. It was Query that funded that. And that's kind of, and basically what the model in the VA is that the health services researchers, and there were like 100, 150 PI level health services researchers in the VA at the time. Some of them have been fired in the last few weeks, but we won't get into that. But and pretty much some of them continued to do just kind of explanatory health services research, which is super important, right? But a lot of us were expected to be able to take something from coast to coast, like in terms of like identifying the problem, quantifying its boundaries, explaining sort of what are the levers you could push to make things happen. This is like the classic three-stage model of implementation science as described by Kilborn and others, right? And then designing and implementing an intervention and evaluating its impact. So I think one of the things that was nice about that research world in the VA, you didn't have to apologize or try to hide the fact that you were doing health services research or implementation science. You didn't have to like try to disguise it as epidemiology to get it funded. Like that's what they wanted to see. But also, it was great in a way that they expected people to be able to take things coast to coast, because you got to have the experience of like developing and then implementing the science. Like it took a long time. It does take
You
a
were
long time.
expected to make research actionable. It
You
wasn't
were
a nice
expected to, and
have,
you
but
had
it
to
was an
list,
expectation.
yeah, and you had to list an operational partner to get anything funded. And you had to
Yes,
have a nice letter from
co-production of
them.
research. That's a gold star. Okay, Adam,
Yeah.
we're running out of time, so
Okay.
we're actually over time, but I just want to ask you one final question. We recently co-authored with Sivan Spitzer, who also we are featuring on this podcast, a perspective in the Israel Journal of Health Policy Research, making the case that Israel has to invest in building the national capacity for implementation science, drawing on lessons from, like you said, the VA or intervention health, et cetera. So if we could do one thing today, what would have the biggest impact? What should we do?
Okay, so I don't necessarily have a ready answer to this. I can think of some big things that would have a big impact. One is like sort of more equitable access to data, which we talked about at the conference earlier this week. Is that data in Israel is controlled by very narrow interests and is not available sort of for research and evaluation in the public good. But leaving that aside, because that's a big nut to crack. Look, I think building capacity and implementation science and health services research, because without both of them, you need to describe first what's wrong with the health system before, or what's suboptimal about it before you can go about changing it. They're both necessary. And I think that investing in those kinds of things, it takes time to build up capacity. It takes time to train scientists. It takes time to rebalance faculties away from a kind of monochromatic focus on epi and kind of adjacent fields. Yeah. And so what I think it takes like sort of far-seeing priority setting and leaders who are not just looking like at next week and what's going to get them through next week. I think it's probably that way with solving Israel's data issues too, is that people have to be willing. There's an old Jewish story. I'm sure not everybody who listens to your podcast is Jewish. There's an old Jewish story from the Talmud about an old man who's planting a carob tree. You can eat from a carob tree. It's partially a source of food. And a young man comes along and says, why are you planting this carob tree? You will never live to, it takes 20 years to really grow carob pods. You're not going to get to eat these carob pods. And he said, just as I found carob trees when I got here, somebody planted those for me. So I'm doing my part, right? So, people's tenure in government may not be 20 years, but you have to, in other words, you can't just there's this whole four quadrants thing, right? Like what's urgent, what's important, what's not urgent, not important. You can't spend all your time on what's urgent, whether it's important or not. You have to have some time that you devote to what is going to do the most good in the long run. And I think that rebalancing Israel's health research towards having at least some health services research and implementation science, and putting it on more of an equal footing in terms of the good it can do for the health system, is very important. It leads to fewer Nobel Prizes. It leads to fewer patents. It doesn't feed Startup Nation, at least from an economic point of view, but it supports creating more equitable, more sustainable, more high quality healthcare that people, can be proud to receive. So that's my answer.
Right. Basically, it may not be sexy, but in the end of the day, it's what improves the health of every citizen in Israel. So,
Yes, I
Adam,
think.
yeah. Thank you so much for your time.
Thank
Greatly
you, Moriah.
appreciated.
Thank you.
And there's always more podcasts to come to explore many more
Are you sensing that I
issues.
like to talk? Are you sensing that I like to talk? Because
I
I
love
had
to
more to
talk to you.
say. I could have said more. But
Yeah. Okay, so thank you
Okay.
so much.
Okay. Thank you for having me. Okay, it was a pleasure. Thanks, Maria.